Thank you, Michael. And my assigned topic's dry eyes, which is not uncommonly associated with blepharitis. So a bit of background first, and then some comments about some of the hot topics in dry eye disease. My disclosures are on the screen. I consult for these three companies. I don't think they're going to impact my presentation. Something that we often forget, the tear film is the most important refracting surface of the eye. Now, we know that with increasing age, the frequency of dry eyes increases. We know that it's more so in women than in men, but it's a very real condition that we face in our daily practices. There are multiple things that can initiate a dry eye. Those are important, but once the dry eye is initiated and the tear film becomes unstable, we have hyperosmolarity, cell damage, cell death, inflammation, and a vicious cycle. We also have the bacterial flora that are present that produce lipolytic enzymes that then perturb the meibomian secretions, and then another vicious cycle. So once it starts, no matter what initiates it, all of these events play a role. Now, there are external factors. So let's look at this from the Hawaii standpoint. Well, we're hardly in an arid environment, but the plane trip here and the plane trip home is where we're going to be exposed to extremely low humidity. Airplane air is very, very low in humidity, around 20%. There's certainly wind here in Hawaii. Pollution's not a big deal. We ought to be working less while we're here and maybe needing fewer of our drugs. But on the other hand, we're apt to have an extra Mai Tai or two, and all of those things can influence the presentation of dry eyes. Keep in mind that a perturbation in any one of the three principal layers of the tear film, lipid, aqueous, mucin, can result in a dry eye condition. So that's just some, off the top background comments to make to lay the groundwork. Probably the hottest topic right now in dry eye, and at this meeting as it relates to ocular surface, is the association of dry eyes with refractive surgery, whether it be keratofractive or cataract refractive surgery. Keep in mind the role of MGD, and I commented on that last year and won't go into that this year. There are a couple of hot topics on the horizon that'll be for another day. There are multiple anti-inflammatory molecules that are on the horizon. There are new diagnostic and therapeutic modalities that are on the horizon. But today it's going to be restricted to dry eyes and refractive surgery. First, keratofractive surgery. We know that this is a real entity. About a third of our patients will have clinical dry eyes after keratofractive surgery. Approaching half of our patients will have dry eye symptoms after keratofractive surgery. And at least early on after keratofractive surgery, there's no real difference in the expression of the problem between PRK and LASIK. And what does this cause? It causes our patients to have fluctuating vision, and they don't understand that in the early keratofractive post-op time. So it's very important for us to pay attention to it. Pathophysiology, well, we're cutting corneal nerves. We're creating a neurotropic epitheliopathy that is the principal underlying cause for this. But also keep in mind that many of the patients that approach us wanting keratofractive surgery are having problems with their contact lenses, and a significant, if not majority, of those patients are having that problem with their contacts because they're developing dry eyes. Duration of the dry eye after keratofractive surgery can be weeks up to a year. The mean is about 6 months, and the recovery tends to correlate with recovery of the corneal nerves and recovery of corneal sensation. Now, there's been a hope that small incision lenticule extraction, so the SMILE procedure, since it cuts across less of the cornea, would have fewer problems with dry eyes compared to LASIK on the left. But indeed, even though the corneal nerves recover more rapidly after SMILE, the incidence and problems with dry eyes is about the same. So it's not going to be a panacea for us. Now, what about dry eyes and cataract surgery? Well, about 10% of our patients will have problems with dry eyes after we do cataract surgery. Keep in mind the MGD pre-op can serve as a marker to let you know that you need to look very carefully for a dry eye condition, whether it's contributing to it or simply a marker for it. The incidence of dry eyes after cataract surgery is much greater when we have added to our cataract incisions relaxing incisions, either LRI or AK. And keep in mind that indeed this condition is treatable with tears, anti-inflammatory, so if we catch it early, we can reverse it very quickly. Well, what is it about our keratorefractive surgery that leads to the dry eye condition? Well, again, we're creating a neurotropic epitheliopathy. LASIK cuts nerves, cataract surgery, the cataract incisions cut nerves. We cut even more nerves with our AKs or our LRIs. And keep in mind also that roughly 10% of these patients that are seeking premium IOLs will also need a laser touch-up. So that all of this raises the issue that we truly need to educate our patients about the risk of dry eyes after refractive surgery, whether it's corneal or cataract. We need to identify the patients who have a tendency to develop dry eyes with surgery, so we need to identify them pre-op. We need to stabilize the ocular surface as much as is possible prior to surgery, because the surgery is going to tip the patient toward dry eyes, no matter where in their functional reserve they are starting with. We need to monitor our patients carefully post-op, so if they do indeed develop a dry eye that we didn't pick up beforehand and stabilize the surface effectively where it would tolerate the surgery, we need to pick it up quickly. We need to watch our patients post-operatively so we can initiate therapy early on. So what can we as surgeons do? Well, I'm going to keep hitting on this. We need to identify the patients pre-op that have dry eyes or a tendency to dry eye. We need to stabilize the ocular surface as much as possible pre-operatively. And we need to plan our surgical approach to perturb the ocular surface as little as possible. And we need to watch our patients post-op, so if indeed they do develop dry eyes and problems with the ocular surface, we initiate therapy early and get them reversed. Now here is, the bottom left has been my major capital equipment purchase in the last, ever, for diagnosing dry eyes, and it's a vital stain. Lissamine green is my favorite. It requires, unfortunately, a formulating pharmacist to produce it. It's not otherwise on the market. And I have no interest in Leiter's Pharmacy, but I just get my Lissamine green from Leiter's. And it costs 2 figures. So no big deal in terms of outlay, and get a bottle, 10, 15 milliliters, and it'll last for a long period of time. And then post-operatively, again, we have to watch these patients so we catch them early and treat them effectively. So, pre-operatively, we need to look carefully. If there's lid disease, we need to deal with it effectively. If one thinks that the patient may have a tendency to dry eye, a nutritional supplement, in other words, omega-3 fatty acids, can be very effective. The study we did suggests that it works as an anti-inflammatory agent. Artificial tears is necessary, anti-inflammatories is necessary, and in recalcitrant patients with significant meibomian gland disease, to consider a tetracycline analog. So in conclusion, dry eyes and refractive surgery, whether it be corneal or cataract, is extremely common. It's frequently underdiagnosed. It decreases our surgical predictability and calculation of our IOL. And it adversely affects the outcomes of our patients postoperatively. It requires an accurate diagnosis. It is reversible, and the sooner we start therapy, the sooner we will be able to reverse the condition and have a happy patient. And it leads to better vision and better patient satisfaction. One thing for us all to keep in mind, that we're dealing with an integrated ocular surface in health and disease. There are many interactions and cascades, complex mechanisms in disease states. There's no simple approach to pathophysiology or therapy. And quite honestly, sadly, but I think true, is that the more we learn, the more we realize how little we know, and in actual fact, how much we thought we knew was wrong. Thank you for your attention.